Just a few more slides here on the treatment options. We have systemic therapies, which includes chemo, targeted drugs, or immunotherapy. There's surgery. We talked about those two different surgeries, one called a Whipple, one called a distal pancreatectomy. And then there's radiation. And you can have a combination of any of all of these. One, surgery, radiation, chemo and radiation. That's why the multidisciplinary interaction is so important. And again, the treatment plan changes depending on what type of disease you have. Is it a tumor that could be removed? And if so, should we give you chemotherapy before or after? In our practice, we typically favor giving some course of chemotherapy prior to the surgery in hopes to A, limit the chance that the cancer has spread already. We just can't see it on a scan. That's called micrometastasis. And we believe in a lot of pancreatic cancer patients that that could potentially be the case, where you come and we only see disease on a CAT scan in the pancreas, but it may have already made its mark on other areas, and giving you chemotherapy before surgery limits the chance that after the surgery the cancer could come back. Locally advanced disease is the type of patient where I think I mentioned where the tumor is involving those blood vessels, and surgery is not necessarily right now safe to do. And so giving chemotherapy in this population is definitely important to shrink the tumor. And of course, if you have metastatic disease, excuse me, where the disease has spread, um, then chemotherapy or systemic therapy, as we call it, is important. Okay, so some of the chemotherapy regimens that we use, there's four that I list here. There again, it's a bunch of alphabet soup, but one of them is called FOLFIRINOX, which is a combination of three different drugs. One is called 5-FU, great name for a cancer drug, combined with a drug called irinotecan and oxaliplatin. The next is a combination of two drugs. One's called Gemzar, one's called Abraxane. And both of these regimens I list at the top, actually all three on the top three, FOLFIRINOX, Gemabraxane, and Nalirifox, which is a newer regimen, are all intravenous. They're IV medications given through what we call a central line that require a chest wall port or a PICC line, which goes into the arm. The third one, called Gem-Cape for short, or gemcitabine and capecitabine, not necessarily our preferred regimen, but this combines IV and oral medications. And all three of these could be used in the before surgery setting, after surgery setting, in the metastatic setting. And there's different reasons why we would pick one over the other, whether it's side effects, quality of life, ability of a patient to get to and from an infusion center, many different factors at play here, and this in and of itself could be an entire lecture on its own. But I just wanted to highlight some of the different treatment regimens. Of course, chemotherapy too comes with its side effects and potential toxicity, which could be fatigue, hair loss, diarrhea, neuropathy. A lot of things like this could happen with any type of cancer or any type of treatment. But one thing that distinguishes pancreatic cancer from, say, breast cancer or colon cancer, which oftentimes are cancers that are diagnosed incidentally. Someone gets a mammogram and they're told that they have a mass, or someone has a colonoscopy and they're told that they have a tumor. They didn't have any symptoms, they just went for screening and were found to have this disease. Then they get put on chemotherapy, not all the time, but sometimes, and they feel sick. Patients with pancreatic cancer are usually the opposite. They feel unwell, they have some symptom, they are jaundiced, they have pain, they have back pain. Then we put them on chemo and they tend to feel better. The treatment makes people's symptoms lessen. But at the same time, we have to balance what the possible side effects could be. So, all in all, in a nutshell, there's obviously way more to discuss about pancreatic cancer in general. I just wanted to give you a flavor for the diagnosis and a little bit about the epidemiology. I have a little summary slide here at the end, and there's way more that we can talk about. But in summary, pancreatic cancer, unfortunately, is a really aggressive malignancy, and the symptoms could be very vague, nondescript signs when they first present. That's why patient advocacy and medical evaluations are crucial from the very beginning until you get the diagnosis and throughout the treatment course. Surgical resection or removal really is the only chance of a long-term survival for patients with pancreatic cancer. But with medications and ongoing medical advances and clinical trials, which are crucial in this space, the landscape of this disease is changing dramatically over the last 5, 10, 20 years. I think I mentioned several times, but all patients with this disease should be presented and discussed at what we call a multidisciplinary tumor board or conference. That way, we get the best and the most comprehensive plan, which could include any or all of the measures we talked about, like surgery or chemo or radiation, or a combination of all the above. So that, in a nutshell, is pancreatic cancer, and it really was a privilege to speak to you all today. Thank you so much for your time, and best of luck.